Good evening, class. We're going to talk for a few minutes this hour. I guess it's actually tonight about the information that we're going to cover in Module 6. In Module 6, if you look um, at your syllabus, is going to be talking about how to complete a UB-04. So um, I think we've already talked about it in the past, but the hospital inpatient claim is started out as a UB-92 until about 2007, I think, and then it changed to a UB-04, and now it's being recognized as a CMS. I think it's 1450. So it's changed names over the years. Some of the form locator fields have changed. Some of the information requested has changed. But it's still, if you talk to most people in the industry, especially in the healthcare industry, whether uh, they're actually billing and coding people on the provider side, or they're analytics or health informatics professionals on the payer side, or even in public policy, if they've been around and been in the business for a while, they're just going to refer to this claim form as just a UB. Yay, we looked at the UB and here's the information we found on it. So uh, you can usually tell how long somebody's been in functioning in the business, working with information off the UB forms. They those of us that have been in it for a while, we'll still catch ourselves either just calling it the UB or calling it a UB-92, because that's what we kind of grew up with in healthcare. And but still, it's a claim form, just like the 1500. It can either be referred to as a HCFA 1500 or a CMS 1500, depending on how long you've probably been in the business. And what I'm going to do on this one is I'm going to go through some examples on how you can tie information together that you can glean from a UB-04. And then I'm going to spend a few minutes going through what I think are some of the more important form locator fields on the UB-04, on the UB. And if you remember, when we were talking about the HCFA 1500 or the CMS 1500, most of those instructions for filling it out were talking about boxes, box 3, box 4, box 5. On the UB, it's more, they're referred to as form locator field, 42. 42 is one that most everybody knows. Actually, form locator, probably 4 is an important one too, where it talks about type of bill. But form locator 42 is where the revenue codes go. Form locator field 43 is where the description goes. And then 44 is where either your CPT goes in, your HCPC goes in, or if it's on a per diem type basis, they may actually put a rate in there based on the revenue code, especially for a room rate. So that's just kind of an overview on how it works. But let's jump in and we'll take off, and I've got some notes written down here. I may kind of bounce around a little, but we'll kind of get you up to speed on how to use the information, and then I'll go through probably fairly quickly on how to fill out the UB form. If you remember that when we were talking about the HCFA 1500, most provider contracts with a payer, when it comes to HCFA 1500, are driven by some kind of a list of values, and we'll call it a fee schedule, are contracted on a fee schedule based on the CPT and HCPC codes. So each CPT code is going to have its unique dollar value. So a 99213, it's the medium level office visit, may have a value with the provider of $75. And so each of those CPT codes and each of those HCPC codes are going to be tied back to a rate on that fee schedule. And when you're talking about paying for, well, I hate to call them non-institutional services, let's just call them medical services. So any provider that is not a facility or an institution, or better terminology, a hospital, they're going to be paid on that 1500, and the CPT code and the HCPC code they will be they'll be the primary drivers for that reimbursement because they tie back to those fee schedules. What you're going to find on the UB is while a UB has on form locator field 44, they can put in CPT codes and HCPC codes that may be tied back to a fee schedule. Most of the reimbursement to hospital, if it's a per diem type hospital, a lot of the fee schedule is going to be tied back to a room rate. So ICU room has a rate. Cardiac ICU may have a rate. The step-down unit may have a rate. The med-surg room is going to have a rate. And they're going to be driven by revenue codes and that they will tie back to rates on those fee schedules. If it's a DRG, it's going to be driven by the ICD-9, or in this case, ICD-10, going to be driven by the ICD-10 CM codes, which are the diagnosis codes themselves, or the ICD-10 PCS codes, which are the surgical procedure codes that are going to take and help the what they call a grouper, help the DRG grouper, and a lot of people use 3M's grouper, and it will take that information along with comorbidities, age, sex, type information and group it into a DRG. So what you'll find on the UB is it's not just the CPT codes and HCPC code information that may be driving some of the reimbursement, especially if it's an outpatient claim. But on the inpatient side, it's going to be mostly driven by those diagnosis codes, either the medical diagnosis codes or the surgical procedure codes. That's going to drive it into a DRG. So it's extremely important on the hospital side to ensure that that claim is filled out accurately. And what you'll find on a HCFA 1500 or a CMS 1500, you'll have providers, they may try to what we call upcode. So patient goes in, it's a medium 99213, and because they get paid more money for a 214 or a 215, you'll have providers try to, and it's called creep. It'll kind of creep it up there to a higher level CPT code to get more money. What happens on the hospital side is they use the groupers, and the groupers, they can play around with, generally it's the principal diagnosis code that has the largest impact on driving that DRG, even though it can hold up, I think it's 17, 18, maybe it's 20 additional diagnosis codes. But with that grouper, you can take and play around with the diagnosis codes, shift the order, shift the sequence on this diagnosis codes, and it'll actually group to a higher level DRG, and it's going to drive more money for the hospital. That's what we call DRG creep. So just kind of keep those in mind as we go through. Again, one thing that sets the 1500 apart from the UB is on the UB, you're going to have revenue codes. And on the UB, you're going to have ICD-10 PCS or surgical procedure codes. You don't tend to see those on the HCFA 1500. I want to talk just a little about Medicare. It seems to confuse not only students, but it really confuses people that are 65 and older, because Medicare is extremely complicated. But if you think about the way it's structured, when you turn 65, you automatically, and you apply for Medicare, whether you apply for, well, I guess you do apply for Medicare, you automatically get Part A. Part A is the hospital benefit on Medicare. If you want the medical or the like physician type services, you have to pay a premium. At least most of us have to pay a premium for Part B. Part C is the quote managed care approach to Medicare. So Medicare, you can either have traditional Medicare, or you can sign up with Humana, Aetna, Cigna, Anthem, United. They all have Medicare Advantage. They call them Medicare Advantage plans. So they all have Medicare Advantage plans, and that's Part C. And then Part D is the Medicare, it's your prescription plan. And most Medicare Part C plans have a prescription plan embedded in that plan. And why is this important? Medicare Part A is going to be billed on a UB-04. Medicare Part B is going to be billed on a CMS 1500 for the most part. Part C is going to take either a UB or a 1500 depending on where the services are provided. We talked about DRG creep, talked about per diem. One thing that you'll find yourself tasked with if you move into the healthcare environment and are playing around with the information at all is you're going to be tasked with being able to take and tie episodes of care together. And we talked in one of the earlier modules about concatenating information, concatenating first name, last name, date of birth, sex, to try to get a unique identifier so that you can follow claims through the system. Let's say that you are admitted in through the emergency room. So you wake up in the morning and your stomach's bothered. You have this shooting pain in your stomach, and you manage to live with it for a couple of hours, and then all of a sudden it just gets unbearable, and you decide to go to the emergency room. You go to the emergency room, and after you sit there and they punch and poke and prod you for I don't know X number of hours, they finally decide you've got appendicitis. And they decide that you've got to get that we've got to pop that thing out, and next thing you know, you're being prepped for surgery. You go in and they either do it laparoscopically or they do an invasive procedure, and you will come back out and they will dump you in probably just a med-surg, probably a med-surg room with with two people, or maybe even a med-surg room with three other people, and maybe a 2-pod or a 4-pod, and they dump you out. And after a while, after you get up and moving, they'll eventually discharge you from home. And so, if your task as a health informatics professional, your supervisor may come in and say, we've gotten a call from Mrs. Smith, and she's complaining about the amount of money she had to pay for that surgery. I need for you to pull me together all of the claims that Ms. Smith generated with this particular episode of care. And so you get out your pencil and your calculator, and you start writing some code, or maybe you've got a coder somewhere, that program that's going to write the code for you and generate the information for you. But you need to understand that you're going to have, more than likely, and actually depending on how the hospital's contract is written with the payer, you could have an outpatient claim for the ER. You could have an inpatient claim for the hospital stay. You could have a surgeon's claim, the surgeon that popped out the appendix. If it was really difficult and it's ruptured and he needs additional help, you may have an assistant surgeon that's going to file a claim. You're going to have an anesthesiologist or or some type of they call them gas passers. You may have somebody that's provided the anesthesia for you. Let's see. You may have some physicians that visited you while you're in the hospital that filing some claims. You could have some claims from a radiologist. Let's say they took an x-ray to make sure your appendix did need to come out. So you've got the potential for multiple claims associated with Mrs. Smith's surgery. And it's going to be up to you as a health informatics professional to pull all of that information together and generate it for let's say your supervisor. So that's one thing you have to worry about. Sometimes you're going to have contracts, especially written for, or at least progressive contracts, that are now being written for what they call episodes of care. And I'm just going to pick on hip replacement. So an orthopod or an orthopedic group at some point, or a hospital, depending on who's going to manage the money, will assume the risk, the financial risk for that hip surgery. And they will negotiate a rate with the health plan or the payer. And let's say they determine that the hip replacement surgery is worth $70,000, whatever that number is. They negotiate a rate, and they negotiate the number of days that rate covers. And so they will negotiate, and they'll say, we'll cover that $70,000 is going to cover a 60-day episode of care. Could be a 90-day episode of care. And so you're going to have to, as a health informatics professional, you're going to have to be able to track that information as it goes forward, because you don't want to pay for any claims outside of that 60-day length or 60-day episode of care, and you don't want to pay for any claims that don't match up with that episode of care. So either the orthopedic group or maybe the hospital is going to serve as the bank and pay out for these claims, and you will start your ticker. So you want to capture those claims from T = 0 to T = 60 days, with T = 0 being the first time that the individual went to the doctor and the physician decided that a hip replacement was needed. So that starts your counter working. And so anything that happened between that episode or that doctor's visit to 60 days out should be covered under that $70,000. And you, as a health informatics professional, are going to have to do a couple of things. Even before they negotiate the $70,000 rate, it's going to be your responsibility to sit down and determine what the appropriate rate's going to be. And so you're working with your network management team, you're working with the actuaries, maybe you're working with the CFO, somebody from medical management, and you decide that, well, you'll cover 60 days. And then at that point, you go in to the information, into your information warehouse, and you start pulling all of the claims for that particular market, for a particular, let's say, medical group. You even pull it down to the medical group level or to the hospital level, and you're going to allocate, you're going to find all of those claims that would happen and cover 60 days, and then you're going to come up with what that average amount should be. And so you, as a health informatics professional, you're going to be driving the financial well-being of your company, of the health plan maybe you're working for. And so it's going to be a huge responsibility to collect all the information accurately to determine that $70,000 rate. So this is on the health plan side. If you look at the provider side, they're going to have health informatics professionals doing the same thing. They're going to be into that orthopedics group, and they're going to be pulling information, and they're going to be looking at a 30-day window, a 60-day window, a 90-day window maybe. And they're going to use that information to negotiate rates. So it doesn't matter which side of that financial coin you're on, you're going to be involved in driving the financial well-being of either the payer side of that financial coin or the provider side of that financial coin. And it's going to be extremely important for you to make sure that you have captured that information accurately. And you can see why. It's going to be you're going to be whichever company you work for is going to be accepting financial risk. And it's going to be up to you as a health informatics professional to be pulling that information. And I think the one last thing we will talk about, on Medicare, again, Medicare pays inpatient services based on a DRG, and we've talked about that. They're referred to as MSDRGs. So if it's, Medicare Part A, it's been paid by an MSDRG, And those MSDRGs are lumped in that major diagnostic categories, MDCs, and they're lumped in there based on surgical procedures or medical procedures. May not be a really good example because we're talking about Medicare, but let's flip back because a lot of commercial health plans, especially in Medicaid health plans, even TRICARE health plans, are paying services based on a DRG as opposed to bill charges or per diem. So we'll pretend like this example is going to be for a commercial health plan, and we're going to talk about labor and delivery. So, individual pregnant goes in to deliver. If it's just a normal delivery, no issues, it's going to more than likely group to a normal vaginal delivery. If a surgical procedure is required, where the baby has to be delivered by cesarean, it's going to, because of the surgical procedure code, it's going to flip to a surgical, it's going to flip to a cesarean delivery. So while the ICD-10 diagnosis codes may be the same, the ICD-10 PCS or the surgical procedure codes are going to drive the difference on that claim between a normal vaginal delivery and a cesarean delivery. You can also have normal vaginal deliveries with complications or cesarean sections with complications. So depending on the comorbidities and the diagnosis and the surgical procedure codes on that inpatient claim, it's going to determine whether it comes in as a normal vaginal delivery, and that's let's say it's a relatively low-paying DRG, as opposed to a cesarean section, which it is a more expensive DRG. And of course, either one of them that have complications are going to boost the DRG reimbursement rate to a higher level. I think that pretty much winds it up on how you can use the information that you can glean from a UB. And what I'm going to do, we're going to stop now, and when I come back, we're going to, and I've got one pulled up on another computer screen over here. I've got a copy of a UB-04 and it happens to be a blank one. And there's a blank one, and some of the information I've loaded for you out on Canvas. Also out on Canvas, I've got loaded a UB-04 that's got some information filled out. I think from what I remember, it may be an outpatient claim, but it's still information on UB-04. So we're going to stop now. When I come back, we're going to go through at least some of the more, what I think are some of the more important information that can be gleaned from a UB-04 and actually how the claim needs to be, or how the billing form needs to be filled out. Talk to everybody again in a few minutes.